Yeah, so unfortunately, there's a large difference in the stage at which people in non-white or Black and African American individuals, as well as Hispanic populations, are diagnosed when they present to a urologist. And we're not really certain if that's if that's due to differences in diagnostic measures prior, or how long it takes patients to notice their symptoms or be referred. So it can be a large number of things that can cause them to present that late for some of these patients, and diagnoses may be different between them as a consequence of multifactorial factors. Oh, absolutely. I think there's a lot of entities that surround the patient before they present. Larger social determinants of health, as well as their own environment, where they live and work, where they raise their children. These are things that can contribute significantly to their medical status. And I think we're still trying to get a better handle on looking at how patients experience those things before they come and present, and why they present at later stages if they do. Yeah, so unfortunately, there's a number of studies that have shown that Black and African American patients, as well as Hispanic patients, experience differences in the type of treatments that they are offered, the type of treatments that are given to them, and as well as different guideline-based management strategies that are provided to these patients. So we know that the treatment is really going to be an important determiner of some of our outcomes that patients have, as well as their clinical stage. So unfortunately, we've seen that quite a few people in these groups are treated a little bit differently for similar stages of cancer, but also present at higher stages at the time of diagnosis, at the time of treatment. So it's a very large issue, unfortunately, and many of those things happen before. A lot of the factors happen before treatment allocation and after. Treatment options can be different for a number of reasons. You described distance, that's an important one. There are some patients who don't live near a NCI designated cancer center or dedicated academic institution, when we know that many of these institutions are good at providing guideline-based care. However, also when patients do present to these institutions, and they still oftentimes are not offered these things, we don't have a good sense of why. A lot of data around implicit biases, as well as patients having higher comorbid conditions, and clinical trials that have historically not included patients with multiple comorbid conditions can also contribute. So it could be a really multi-level reason for these. It can be system-wide, being limited in the location and proximity to certain resources, as well as the system itself treating African American and Hispanic patients differently once they arrive, and then also prior to treatment regimens as well. Yeah, some important probably larger scale things, looking at the system level. There are a lot of factors outside of the patient that the patient and either the provider can really control and mitigate, and looking at how communities can be engaged to allow for better access to care that has been noted to be associated with improved survival, and also really targeting these patients in these populations that we know historically have had worse outcomes. I think it would require a lot of paradigm shifts about how we think about care of these patients, and really look at more pointed measures, looking at them specifically. A lot of healthcare has been directed towards very specific populations and really excluded those that have had poor outcomes, and I think this is the result. I think some large important scale things would be enhancing the accessibility of clinical trials, as many of those can offer innovative treatments at lower cost to patients, but also making those in communities that participants or patients in these typically excluded groups can participate in.